Sorry, this is our first rounds of this season, and we are pleased to welcome three speakers from London Health Sciences Centre to present today about elective repeat cesarean section, the London Health Sciences Centre experience. So before I introduce our speakers, just to remind you all and let you know, this round will be recorded, as you all heard. We post the rounds as a webinar on our Bourne website. So for any of your colleagues who aren't able to join us today, they will be able to go and listen to the presentation later. We normally have the presentation in its entirety first and then allow time for a question and answer period following the presentation, just so we make sure we get through the information that the presenters have prepared. We will be able to either have your questions for the question and answer session typed into the chat box that you should see at the bottom left-hand side of your screen, or you can phone in to a phone line if you are interested in calling in by phone. To put your call into the phone queue, you press 01, and to take yourself out of the phone queue, you press 02. But I'll remind you of that when we get to the end of the presentation. This topic, just to introduce the topic for you, elective repeat cesarean section, is about one of the key performance indicators on our maternal newborn dashboard, a dashboard that the Bourne Information System, once it was launched in 2012, the dashboard is a reporting feature within the Bourne Information System, and it was launched November 19th, 2012. And so this story that we will hear from the London Health Sciences Centre team is about their experience related to one of the key performance indicators on the dashboard, and that's with respect to elective repeat cesarean sections done before 39 weeks gestation. So I will let them to describe the objectives. I know they have a slide to show those when they start off. And without further ado then, I'd like to introduce Dr. Chandra, who is a third-year resident, obstetrical resident, Dr. Natali, who is the chair of the Obstetrical Neonatal Quality of Care Committee and was the chief of obstetrics for over 20 years, and Dr. Gratton, who's the current chief of obstetrics. So I'll pass over to the group, and we'll enjoy the presentation.
Good morning, everybody, or good afternoon. I guess it's official afternoon. I'm Renato Natali. I'm one of the maternal fetal medicine specialists in the group. And then I'm going to start, and then Naharka is going to do the second portion, and then Rob Gratton will do the last few slides to tell us what we're actually doing about our problem. So by first slide, basically the objectives. Basically our objectives today are to present medical evidence for timing of elective repeat sections greater than 39 weeks based on the maternal and fetal outcomes, and to also show the utility of Bourne dashboard to measure and provide ongoing audit of the timing of elective repeat cesarean sections, and then to discuss strategies to improve the percentage of elective repeat sections performed greater than 39 weeks. And really, by way of background, I really am going to also talk about our perinatal database as well as what the cesarean section rates are in our country. And if you take a look at the rate of cesarean birth by province put forth in 2010 to 2011, you'll see that while the WHO organization, the World Health Organization, thinks that our section rate should only be 15%, you see that we're way beyond those numbers. And in Ontario, really, we're basically about 28.3%, and BC leads the way. I don't know what it is in Quebec, but essentially we're way above those kinds of numbers. And again, if you take a look at cesarean sections and ask the question, who are the contributors, repeat cesarean section, once somebody has had a cesarean, seems to be one of the particular groups of interest, because essentially in our country, we do an elective repeat cesarean section on somebody that's had a cesarean section. And you can see that Manitoba kind of sticks out as being less than, like, probably about 70%. And you can see the Nunavut basically is way down at about 40%, which means that 60% have had a go at trying to deliver vaginally, okay, and have actually succeeded, okay? So that's kind of an interesting thing to keep in mind. And then if you take a look at repeat cesarean section rates in Ontario, according to LHINs, the only LHIN that stands out is really the Southwest LHIN, LHIN 2, which happens to be the LHIN that we're in. But actually our numbers in 2010 to 2011 were still only 70% that we did repeats in 70%, so only 30% were given an opportunity to try to deliver vaginally. So we still have some work to do, and I'm going to show you some data that actually really address that. And again, if we take a look at the point that we're trying to debate today, that is that the number of sections that are done prior to 39 weeks, you see again that we're not particularly doing very well, and so we specifically have a problem that we need to correct. And you can see that there are some sections that are being done less than 37 weeks, and then the bulk actually are done after 38 weeks, but still less than 39 weeks. So overall, the cesarean section rate in our environment, and these are numbers that we've derived through our database for prior to amalgamation. And historically, we were two institutions. We were a level 3 and a level 2 unit. We had a single department which was citywide, and we've done that now for quite a long time. So essentially, we functioned as one group, but with two different environments. And you can see that the cesarean section rate in the tertiary care unit was about 25.5 or 35%, and about almost 21.5% at the level 2 unit. Okay, and we started way back in 2000, where it was sort of 19 and 18%. Those were the days when the cesarean section rates were really low. And then if you actually ask the question and say, what is the cesarean section rate among low-risk nulliparous and low-risk multiparous at St. Joe's level 3 and at Victoria Hospital level 2, you see that those numbers basically tell you that, in fact, in the tertiary care unit, we had a blip, and then we kind of settled back down to about 8%, and at Victoria Hospital, we were really running about 10%. And if you take a look at the nulliparous patients, basically, if you're a healthy if you take a look at the multiparous patients, if you look at them and say if you come in labor and you have no identified risk factors, either obstetrically, medically, surgically, you have a well-formed baby, the thought is that the baby is well grown, that's how we defined no risk or low risk, you'll see that their cesarean section rate is really only about 2%, which is actually kind of a nice way to look at what you're doing in your unit. And so we've taken great pride in actually looking at this over time to see that we're on the right ballpark. And then of recent, in the last 2 years, we've actually converted all our cesarean section rates in the past using the Robson criteria. And basically you can see that group 2 and group 5 are the specific groups that really lend themselves to cesarean section. And group 5 is the group that actually looks at all women that have had a previous cesarean section. And of course, the ones that you and I should be primarily interested in are the ones that have had one previous section only to trial them for labor. And then, of course, with the born dashboard, we really want to know that those cesarean sections, when they're done repeat, that they're done after the 39th week. Okay, and again, you can see that the group 5 group is really the one that's actually contributing to the increase in cesarean section rate. And if you take a look at all the other groups, they're really not particularly different over time, and that applies to both the level 3 and the level 2 units. So there's been a little bit of an increase in cesarean section for other reasons, but you'll see that the biggest contributor to our cesarean section rate then really becomes the repeat cesarean. So in a sense, we've kind of dropped into that deep well of once a section, always a section, and that we've tried to really stay out of. Okay, and this is again the contribution of cesarean section among single cephalic pregnancies greater than 37 weeks with at least one previous uterine scar. And you can see that we suffer from the exact same problem that everybody has, in that we're doing way more repeat sections than we perhaps should. Okay, and this again emphasizes that in both the level 3 and the level 2 unit. Okay, and so now we're going to take you through the existing guidelines in terms of what is available out there in terms of when we actually do the cesarean section, if we're going to repeat it.
Hi, my name is Niharika. I'll be presenting the next part. So let's start with some existing guidelines. According to the American College of Obstetrics and Gynecology, they had a guideline in 2007 that stated that cesarean deliveries on maternal request should not be performed before gestational age of 39 weeks. And the exceptions for that would be documented lung maturity. However, they changed their guidelines in 2013 as a recommendation statement, which excluded the documented lung maturity. So now it's just cesarean delivery on maternal request should not be performed before 39 weeks, and that's it. In the UK, the National Institute of Clinical Excellence stated in April 2004 that the risk of respiratory morbidity is increased in babies born at cesarean section before labor, but this risk decreases significantly after 39 weeks. Therefore, planned cesarean section should not routinely be carried out before 39 weeks. The Royal Australian and New Zealand College of Obstetrics and Gynecology stated also something similar in 2009, recommending that again, elective cesarean sections should be carried out at approximately 39 weeks. And what they mean by these types of cesarean sections is breech presentations and uncomplicated repeat cesarean sections. Now, for Canadian guidelines, unfortunately, we don't have any Canadian guidelines concerning this, but the bottom line is that all clinical management guidelines recommend delaying elective repeat cesarean sections to 39 weeks when possible. So, are we compliant to these guidelines and around the world? So these are three studies that I presented. So PETA et al. Is a multi-center cohort study in the United States, and they had 6.3% at 37 weeks and 29.5% of cesarean sections at 38 weeks. Wilmink et al. In 2010 in the Netherlands presented a 56.6% of elective repeat cesarean sections were performed prior to 39 weeks. And in Turkey, Ergotrol et al. In January 2013 presented that 54.6% of cesarean sections were done at 38 weeks and 10% were done at 37 weeks. So no, we are not compliant around the world. According to Bourne, the dashboard indicates that we are not compliant for elective repeat cesarean sections after 39 weeks, specifically in women with no maternal or fetal risk factors. And if you look at the data at Victoria Hospital at the LHSC, this is data from April 2012 to January 2013, and it shows a total of 58.8% or 58.8% of surgeries for low-risk women who had a previous cesarean section. Their repeat was done from 37 weeks to less than 39 weeks of gestation. And if you compare the statistics at Victoria Hospital with other hospitals with a birth volume of more than 4,000 per year, we're a little bit higher, but the other hospitals are also at 52.8%, and all of Ontario is at 52.1%. And the Bourne Ontario sets targets, and we are above this benchmark rates, and we're in the red alert zone, and this is red alert zone happens after 15%. The next question would be, why aren't we compliant? Some reasons suggest in literature that it's convenience of the surgeon and patient. There's lack of awareness around the risk of carrying out a slightly earlier delivery. To ensure the patient's own doctor performs the procedure, so we're not doing the procedure at an emergency cesarean section condition. Patient's unwillingness to prolong pregnancy, so social factors, and to avoid the onset of labor and maternal morbidity that's associated with emergency cesarean sections. So the next part, I'll be talking about the timing of elective repeat cesarean sections and neonatal outcomes. I'll be presenting some studies. The first one was presented by Tira et al. In 2009 in the New England Journal of Medicine, called the timing of elective repeat cesarean delivery at term and neonatal outcomes. And their objective was to assess associations between elective cesarean delivery at term, which was from 37 weeks or longer, but before 39 weeks of gestation, and the neonatal outcomes. And their patient cohorts were patients who were going repeat cesarean sections, and they're performed at 19 centers. So it was over 13,000 patients. And they found that 35.8% had a repeat elective cesarean section prior to 39 weeks, and 49.1% were performed at 39 weeks of gestational age. And again, this was absence of labor or other recognized medical and obstetrical indications for delivery. Their primary outcome was a composite and included the list that you see on the slide, including admissions to the NICU, prolonged hospitalization for more than 5 days, hypoglycemia, adverse respiratory outcomes, and these neonates were followed until discharge from the hospital or 120 days after birth. So as you can see in this figure, the results show that at 39 weeks, if you did a repeat elective cesarean section at 39 weeks, the incidence of the primary outcome was at 8% and 7.3% at 40 weeks of gestational age. And it was a much increased percentage of neonatal outcomes at 37, 38, or 41, 42 weeks of gestational age. A little more detail, this slide shows the different parts of the primary outcome. So if you look at the admission to NICU, the admission to the NICU was 12% for when the repeat section was done at 37 weeks versus 6% done at 39 weeks. And any adverse outcome or death was 15% if done at 37 weeks versus 8% at 39 weeks. This slide shows the odds ratio, so 39 weeks being the reference point. So a little more detail to give you an idea is that the risk of hospitalization of greater than 5 days was higher for delivery at 37 weeks by a factor of 2.5 when compared to a delivery at 39 weeks. And for example, the risk of RDS, if done at 37 weeks, was a higher risk by a factor of more than 4 compared to a 39-week delivery. So that paper also had additional analysis, and one of the interesting factors that came up with was that the risk of a primary outcome, even if it was done from 38 and 4 days to 38 weeks and 6 days, which was a couple of days before 39 weeks, the recommended 39 weeks gestational age. And in their paper, that was 51.9% of the deliveries was in the time from 38 weeks and 4 days and 38 weeks and 6 days. The risk of primary outcome was still higher than the risk at 39 completed weeks. And they mentioned that postponing elective repeat cesarean sections to 39 weeks could have prevented 48% of cases of primary outcome at 37 weeks and 27% of cases at 38 weeks. So most studies are unable to conclude the effect of delaying elective repeat cesarean sections to 39 weeks on stillbirth rates due to a small sample size, and this is a concern that a lot of physicians have because they think there's an increased risk of stillbirth rate. However, a paper presented by Intermountain Healthcare, they published a paper displaying their results on neonatal outcomes after implementing a policy that delayed most of the elective deliveries to after 39 weeks of gestation, as opposed to 37 weeks to 39 weeks. And they actually showed that the stillbirth rate fell by more than 50% for each gestational week past 37 weeks. So if you look at the percentage at 39 weeks prior to implementing the policy was 0.07%, and it remained kind of stable at 0.05%, so it was not statistically significant after implementing the policy of doing elective repeat cesarean sections after 39 weeks of gestation. So in summary, neonatal outcomes for elective repeat cesarean sections prior to 39 weeks of gestational age or in a low-risk population showed an increase NICU admissions, increased TTN, increased RDS, increase in ventilator support, increase in suspected or proven sepsis. The next portion, we'll talk about the timing of elective repeat cesarean section and maternal outcomes. So the first paper is presented by Tita et al., and this was presented in 2011, called The Timing of Elective Repeat Cesarean Sections, Cesarean Deliveries at Term, and Maternal Perioperative Outcomes. And they tested the hypothesis that delivery at 37 or 38 weeks of gestation, as compared to delivery at 39 weeks of completed weeks, is associated with a reduction in adverse maternal outcomes. And again, their cohort study was a group of patients with repeat cesarean deliveries performed at 19 centers, and they had a little more than 11,000 patients. And again, this was in the absence of labor or other recognized medical and obstetrical indications for delivery. They had two sections to their conclusion, which was primary outcome and alternative outcome. The alternative outcome included death, hysterectomy, or uterine rupture, some severe outcomes. And their results overall did not show trends that were statistically significant. So there was a trend showed the need of blood transfusion decreased with an increasing gestational age at cesarean delivery, and this could be perhaps due to the development of the lower uterine segment, and it's not optimal for avoiding blood loss prior to 39 weeks. And it could be due to its relations to adhesions to prior surgery. And they also showed that maternal hospitalization greater than 5 days was decreased with increasing gestational age. And this could be because there was a stronger association with prolonged neonatal hospitalization and not with an earlier delivery. And this association was almost twofold, shown here. So this study is limited to unlabored cesarean sections, so it doesn't account for any effect that labor has on the outcomes. And we all know that more than 10% of women go into spontaneous labor between 38 to 39 weeks of gestation. So the next study presented here is by Chelsea et al., and they showed their objective was to compare the risk of an elective cesarean section delivery at a specific gestational age to the risk of delivering at a later time. And their database was from 19 centers from 1999 to 2002. Again, their database was broken down, and the circled in red is the cohort that we're looking at, which is more than 14,000 patients. And this was, again, elective repeat cesarean section without delivery, and it's compared to those with delivery or at a later gestational age of delivery. So the rate of a composite maternal outcome was significantly higher among women electively delivered at 37 weeks of gestation when compared to women with who were expectantly managed. But it was significantly lowered among 39 weeks of gestation when compared to a later delivery. So these composite maternal outcomes include death, pulmonary edema, etc., including blood transfusions. And again, in detail, the blood transfusion incidence was higher among women delivered at 37 weeks as opposed to ones expectedly managed. And the rate of pneumonia was increased and was more frequent with elective deliveries at 37 weeks of gestation, and a cesarean hysterectomy was more common in those who were still pregnant after 39 weeks. This article did not mention the rate of emergency cesarean sections and whether any of the risks and complications with expectant management were related to the emergency cesarean sections. This article also does not mention the rate of newly diagnosed complications such as preeclampsia or gestational hypertension with expectant management. Again, to go back to the Intermountain Healthcare study comparing outcomes before and after a policy was implemented to have deliveries done at 39 weeks or later, they were the only ones that systematically evaluated maternal morbidity after reducing elective deliveries before 39 weeks, and they showed that there was a slight decrease in postpartum anemia and the number of cesarean deliveries performed due to fetal distress when after this policy was implemented, and there was a slight increase in mild preeclampsia, but there was no difference in infectious morbidity. So overall summary, like mentioned before, the neonatal morbidity significantly decreased when CSs were delayed to after 39 weeks. Maternal morbidity is not overall significantly increased if elective repeat cesarean sections are delayed to 39 weeks, but more randomized controlled trials are needed to answer all risks and benefit questions as to the best timing of a scheduled elective repeat section. So what can we do to implement the guidelines? So we can compare them. We can compare our experiences with other institutions and what they have done and learn from them. So one article again by the Intermountain Healthcare Quality will go into more detail with this. It's by Oshiro and al. And they had a multidisciplinary team of physicians, nurses, leaders, and nurse leaders and statisticians and administrative leaders, and they developed and implemented a program to decrease the number of early-term elective deliveries, and their policy and implementation went from 2001 to 2006. It was done over 9 urban facilities in Utah. And within 6 months of implementing the policy, the elective deliveries done before 39 weeks dropped from 28% to 10%, and was even less than 3% after 6 years of implementing this policy. Another article showing implementing a policy and their experience was by Clark and al. And this was a retrospective cohort study at 27 hospitals in the United States. And their objective was to examine the effectiveness of different approaches to reducing elective early-term deliveries, and to examine the effect of such policies on NICU admissions and stillbirth rates. So they had 27 hospitals participate in this study and policy, and they were divided into 3 groups. Policy number 1 was called the hard stop group, and this prohibited purely elective inductions and primary and repeat cesarean deliveries prior to 39 weeks. And this policy would be enforced by hospital staff members who were empowered to refuse to schedule any such deliveries. However, questionable indications could be handled in a standard manner by assessing the chain of commands. Policy number 2 was a soft stop policy, and in contrast to the hard stop policy, the compliance would be left up to the individual physician, and the elective deliveries at 39 weeks of gestation would be allowed if it was ordered by the attending physician. And the third policy was purely educational, so the administrative staff and other participants in this research would go around giving lectures, like we're giving one, and educating others on maternal and neonatal outcomes of early term cesarean deliveries. So this was policy number 2, just by education. And they compared their outcomes from May and July in 2007 to May and June, July, the same part of the year in 2009. So their results showed that both Group 1 and Group 2, which was hard stop and soft stop, demonstrated a significant decline in the rate of elective early term delivery over the study period. Group 1 experienced twice as great of a reduction as Group 2. There was a decline in Group 3 also. However, the change was not statistically significant. So their conclusion was that their rate of elective delivery between 37 to 39 weeks of gestation fell from 9.6% to 4.3%, which was a 55% reduction. Their NICU admission rate decreased from 8.9% to 7.5%, and this was a 16% decline in overall term newborn intensive care unit admissions, and there was no change in the stillbirth rate.
So just to summarize what we've covered so far, we've set the context of cesarean section really nationally and across the province and here at London Health Sciences Centre. We have identified our problem here at London Health Sciences Centre. I think we share it with a lot of centres across Ontario, that we're doing a lot of elective repeats less than 39 weeks. We've looked at the guidelines, which are quite clear that we should strive to do these over 39 weeks. We've looked at both the maternal and neonatal evidence, which backs up those recommendations. And what we have decided to do here is to adopt a soft stop policy to try and reduce our elective repeats less than 39 weeks. We have 3 sort of components to this, which I'll review in the next 3 slides. The first is around education. The second is around some process improvements that we've made. And then thirdly, around audit and feedback of our performance to try and reinforce good behavior. So the objective really was very simple. It was to reduce our incidence of elective repeat cesarean section less than 39 weeks and to become compliant with the benchmark set by Born Ontario. The first thing we did in education was the Born data and the data from our comparators was reviewed by the Maternal and Newborn Quality of Care Committee. And this has been one of our strategic objectives that has been taken up by the committee led by Dr. Natali, and is one of our priorities over the next year, is to reduce this incidence and become compliant. The direction from that committee was that we actually present our data at our obstetrical clinical meeting, which we did, and reviewed the Born dashboard in its entirety, but specifically this one in which we were not compliant. We then had grand rounds, OBGYN grand rounds, and the HARCA did that, and we invited our other stakeholders, anesthesia and pediatrics, and reviewed essentially what we're reviewing with you today. Finally, we were able to obtain physician-specific data. We haven't released this yet, but as part of our process going forward, we will, so that each of us will actually have a report as to what percentage of cases that I do where I book an elective cesarean section less than 39 weeks. And our hope is that providing physician-specific data in a confidential manner will improve our performance. So those are the things that we've done related to education. In terms of process improvements, we've actually gone to electronic bookings. Prior to this, we had a paper-based booking system, and one of the complaints that we had was that we weren't able to track in real time what was happening in our booking system, so that someone may have come in and delivered in labor, so they came in labor, were delivered, but they didn't necessarily fall out of that book consistently because of a paper-based system, so we weren't booking in real time. Having switched to real-time booking, then in each of our offices, we can see how many spots there are in our elective spots tomorrow, later this afternoon, next week, and it's all being tracked in real time so that we can book our cesarean sections over 39 weeks and not be blocked out by cases that actually aren't even there. The second thing we did is we actually changed our booking form. Now, this is electronic, but the changes we made is we asked people very specifically to identify both maternal and fetal risk factors. That was indicated in our previous booking, but it was booked as risk factors and wasn't filled out rigorously. So we've actually have a section on maternal risk factors, fetal risk factors, and if there are none, we actually make people check off no risk factors. And as a follow-up to that, we make them enter gestational age at date of cesarean section. So not just estimated date of birth, but what is the gestational age at the date of cesarean section? And we're looking into electronically whether we can actually create a flag that will come up electronically. If you identify no risk factors and gestational age less than 39 weeks, the computer will then speak to you and say, are you sure that you want to book this cesarean section at less than 39 weeks? And finally, real-time data entry into BORN. So we have been not putting in our delivery data real-time up until now, and that created a lag time between our data quality assurance that was uploaded into BORN, and it didn't make us nimble because we couldn't react nor could we feed back decline in performance or improvement in performance. So one of our objectives over the last 3 months is to develop real-time data entry, and I'm happy to say that in September we plan to go to real-time entry into BORN for all of our delivery data. So those are the 3 process improvements that we made. Lastly, evaluation, audits, and feedback. So the real-time data entry will allow real-time feedback. And we plan to track our data monthly, both at the Patient Safety Quality of Care Review Committee, and it also will be featured on the OB/GYN clinical meeting, the citywide agenda, each month. So we will be providing feedback globally to all of our care providers as to how we're doing. Secondly, as I mentioned before, we're going to have physician-specific data, and we plan to audit this quarterly and provide confidential feedback to each of the care providers so that they know how their performance is individually. And our hope is, with this method of education, with some process improvements and ongoing evaluation, audit, and feedback, that we'll be able to see similar effects to what they saw in the studies that Naharika presented, and we'll see a dramatic reduction in our elective repeats less than 39 weeks. I didn't show you our most recent data on BORN because we're still in the 50 to 60% range, but again, our most recent data is April, and we're just rolling out a lot of these initiatives that we've showed you in the last 3 steps, really at the beginning of the summer, but now more rigorously as we enter into the fall. So thank you very much for your participation and attention during our presentation, and we would certainly invite any questions that you have, or advice that you have that you might have learned in your own center. Thank you.
Thank you so much. What a wonderful presentation, a great review of the evidence, and wonderful overview of how you evolved to identify and develop the strategies that you've put into place. And actually, my question was going to be to ask you sort of when your rollout happened, when you would anticipate seeing some change, but you have already addressed that. So I'll just remind everybody again, welcome questions. You can either put your question in, type it into the chat box, the lower left part of your screen, and we'll wait for a minute. I don't see any questions coming up just yet. Or you can call in to our phone line or put your call into our queue by pressing 01. And you can take your call out of the queue by pressing 02. So just while we wait for a minute to see if we do have any questions, I wondered if I could ask you about sort of availability of resources around, you talked about scheduling your booking times as being one of your strategies and developing an electronic scheduling system. One of the barriers to, or one of the triggers for the elective repeat, the early elective repeat cesarean section that we found in the pilot study we did before the dashboard was launched, there was a pilot study done in the Champlain Lynn, and one of the triggers to the cesarean section rates was not just about scheduling, although that was an issue. People talked about availability of OR time and staffing around booking, the sort of the availability of people around scheduling cesarean sections at certain times. Did you find out, or can you comment on that? Is that an issue, a part of the issue that you deal with in London, or it doesn't seem to be an issue?
I think it certainly has been identified as part of the issue.
Okay.
We have a certain number of elective cesarean section spots spaced out over the week, and on some days there are more cesarean sections that need to be booked than there are spots available.
Yes.
But I think it's a bit of a misnomer, because there is a certain volume of cesarean sections that need to be done or will be done. And if we're doing them too early, it's not that we've audited and we know that we have enough spots. Our utilization of our spots in total is about 80 to 90%, so there are actually spots going empty. So it's, I think, a matter more of shifting those spots, shifting the bookings from where they are now, and most of these are booked 38 and a half, 39 weeks. If we can just get everyone in the mindset to shift them, the resources should be there. It's just that we're occupying the wrong times.
Yeah.
The other problem that we had was that people were booking cesarean section, repeat cesarean sections when they first saw them at maybe 20 weeks. And were kind of gobbling up the spots, if you like, and so that created a stumbling block for cesarean sections closer to when they should have been done. So, for example, if you were sort of constantly trying to book the cesarean section after 39 weeks and you didn't book it until 38 weeks, you couldn't get a booking time. So that, it taught people bad things. And so we had to, as a department, said, look, you can't book repeat elective cesarean section prior to 36 weeks. So we have some rules in place, and as Rob said, we've also, had the discussions with anesthesia, and we've actually modified some of the times that they've made available for us for repeat cesarean sections. And the other thing that was also done is when we moved and amalgamated, one of the issues was to see whether we could have booked elective cesarean section time throughout the week rather than just 1 or 2 days a week. And I think that that's also helped us immensely in terms of really trying to answer that access point. Okay.
Thank you. So we have a flurry of questions coming in. So just one that came in to me, I believe, from Anne, and she says, is London willing to share the content of your booking form? Is that possible? Yes?
Sure. Yeah, absolutely. Yeah,
okay.
Yeah.
Okay, well, we can born...
It's a bunch of pages on our health, on our patient information system.
Okay. So we can probably...
Go ahead.
No, you go ahead and finish. So
what I was going to say was we're also going CPOE next May or April. So our thought was that as we develop this booking form, we may actually stick it on some orders. In other words, you can have a pre-admission and order forms, the whole thing about where the consent is and what's on the consent and et cetera, so that it could become really a neat package. So and that's kind of work that we haven't done yet, but we're kind of thinking in that direction.
Okay.
So absolutely, we could share.
Okay, we can certainly help to facilitate that then and pass on connections to you. Another question from Rebecca. She says, are any level 1 hospitals having a difficult time with this, especially when the OBGYNs have only 1 OR day weekly? And that, I think, is getting at some of what you were just talking about, although not from a level 1 perspective. is access to the OR time and the human resources to run the case.
I can take that on. I must say I run the outreach prenatal program in the Southwest, and and so part of the mission really is that whenever we go visit the community hospitals and the surgeon's going to do the repeat cesarean section, we basically have insisted on the units in saying, look, you must not repeat the cesarean section prior to 39 weeks. If that is all, like, so the only reason they would be doing it in the level 1 is that there are no risk factors, and so it would be an absolute mandatory event. And I must say, we tend to probably have better luck with the smaller community hospitals than we do in our own environment, where we have, so many other, what should I say, demands on the times that are available. So,
okay.
So, but I think that, maybe I'm speaking out of turn, but obstetricians, if they do have only a particular day, then they need to be sure that the elective time that's set for cesarean section can't just be that particular day. So they need to look at strategies to change that. Prematurity trumps everything.
Kemi asked, how do you calculate your gestational age? Do you use first ultrasound or last menstrual period, or do you have, what rules do you follow?
Well,
I'll go ahead.
I'll go with that. Well, the most accurate is your first trimester ultrasound. So it should be according to that, and according to the guidelines, if you have a last menstrual period and a first trimester ultrasound, if the days are 5 days off, then it should be according to the ultrasound. And if you have a last menstrual period and a second trimester ultrasound, if the days are 10 days off, then it should be according to the ultrasound. So we try to use at least one ultrasound should be done in the pregnancy, and we try to use that to make our decision.
Okay, thank you. Michelle asks, is there data on elective repeat cesarean section for post dates? I'm a midwife, and many of my patients who choose elective repeat cesarean section are post dates, opting out of cervical ripening and induction of labor.
What sort of data were you thinking? You mean like stillbirth rate? Is that?
It doesn't say.
I practice that as a general option for women that would like to try to go into labor and then make a decision about whether or not they're willing to be induced. So I do offer induction for somebody that's had one previous cesarean section. Mm-hmm. Okay. And so it's an ongoing discussion, and then they may decide that they get to 41 weeks, nothing has happened, then they need to decide whether they're going to have an induction or going to have an elective repeat section.
Okay.
And I think most of my colleagues probably practice some of that. And I don't know, Rob, do you want to comment?
No, I agree. I mean, I think that I can't give you any data on maternal and liver outcomes, but I think certainly with post-date surveillance, it's reasonable to have someone wait, and if they ultimately decide to wait till 41 and a half weeks, their cervix is unfavorable and the presenting part unengaged, then I will do an elective section at that point in time.
Okay. Actually, Michelle, I think, is responding back to the question about, or Kemi is responding back to a previous question. She says, yes, Rebecca, as level 1, we experienced difficulty with the OR day. I think she's just agreeing, coming from a similar level site with the previous participant's question. Michelle clarifies her question, says, I meant as a general reason for the increased cesarean section rates. And Michelle's question was the one on, is there data on elective repeat cesarean sections for post dates? So I'm not sure we're actually understanding her question or not, but.
Okay. I guess basically my thinking would be, the way that I present it to patients is that if they go into spontaneous labor between 37 and 41 weeks, their chances of having a cesarean section is really, that's why I presented those numbers before. their chance of having a cesarean section, if you're a multip, it's really only about 1.5 to 2% at most. Okay, so there's a background noise. We all have a cesarean section rate. If you're a nulliparous patient, your section rate is probably about 8 or so %. Once they go post-date and you induce them, their cesarean section rate is basically 2.5 times what their cesarean section rate would otherwise be if they went into spontaneous labor. And that's kind of a simple rule. Okay, so then if somebody needs to have an induction, we already know what the cesarean section rate is for an induction post-date. I think the cesarean section rate for somebody that's had one previous cesarean section is really somewhere between 20 and 30%. That's what the numbers are. And in our own institution, that's exactly what they've been, and they've been that for years and years and years because we've looked at it. So if we actually give, and there was a time when about 80% of our patients actually had an opportunity to try to deliver vaginally, if they had one previous cesarean section, our success rate on a monthly basis is somewhere between 65 and 85%. And I don't know why the variation, but those are the numbers that we've had for years and years and years. So the truth of the matter then is that if you're induced and you're post-date and you've had a previous cesarean section, your risk of having a cesarean section is probably a 50-50 proposition. And that's the way I present it to people. And some people bow out and some people bow in. I don't know if that's good or bad, but that's just the way it is.
Okay, thank you. Anne asks if you could tell us what is the electronic booking system you are using. Is it part of your hospital booking system or is it some other product?
It's part of our hospital booking system. We're on a Cerner system here. So we've developed a booking module within Cerner around around cesarean section. Cerner,
is that how you say it? I don't know the system, so.
It's S-E-R-N-E-R. Cerner.
Okay.
C-E-R.
I'm sorry.
C-E-R-N-E-R.
CERNER is the electronic booking system for anyone who's listening. A question again from Kemi saying, do we have any data available to show how many dollars that we could save if we as a province adopt this safe practice? And if I could just preface your comments to let you know that the Maternal Newborn Outcomes Committee in Ontario, which is a expert panel of clinicians, epidemiologists, researchers, advisors about maternal newborn care practices, they have a working group actually working on a project that will be a cost analysis looking at this particular key performance indicator. So the project is defined at this point. The ethics approval is received. The data we're just waiting on, and so we hope in the future, through next year, to have some additional information that's Ontario-specific data related to a cost analysis. I don't know if you have any additional information you can share from your area about costs.
We don't have any cost data here, but thank you for answering the question for us.
Okay.
We've been interested in a long time. We think it'll be huge.
Yeah, okay. Well, stay tuned, right? That's the last of the questions on the chat line. I'm just going to pause for a minute and check with Laura, who's on our line, our admin assistant, just to see if she has any questions in the phone queue.
No, there aren't any questions in the phone queue.
Okay, thanks, Laura. Okay, I have just a comment to make, and it's not based on a question that's come in as a result of this presentation, but a question that has come in the last few days in relation to this, the whole issue of elective repeat cesarean section, and I think the agreement or the ability for people to be comfortable to accept that this is a safe practice to implement. And it really is around the issue of, but there are medical justifications and needs, times when an early elective or an early repeat cesarean section is necessary. And yes, absolutely. And what I wanted to do was just to re-emphasize with our listeners, for those who might not be as familiar with the definition of the indicator, that this key performance indicator is specifically designed around very low risk cohort of women who are not in labor, who have had a previous cesarean section, and for whom there are no obstetrical and medical complications that would warrant the need for an early cesarean section. And I know you described that in your slides as well. You emphasized that. But just to make the point that this initiative is not to change cesarean section rates inappropriately and in an unsafe way, but to look at the cohort of women for whom there is no other apparent reason for the well-being of mom and baby that you need to do the cesarean section less than 39 weeks. And then if there are obstetrical medical complications, that is taken into consideration in the decision-making that goes on with the physicians and the families about the best time to section. So just to clarify, this key performance indicator is really targeting cesarean sections, not the reason for doing the cesarean section, but the timing of doing a cesarean section, that there is no other reason that it needs to be done early. So we've tried to define our key performance indicator very explicitly, and the rates that are calculated and profiled on the dashboard, on the Born Information System dashboard, and the comparator rates are all calculated in a very low risk cohort of women. So I just thought I would take the opportunity to plug that and to reemphasize, just in case there's a little bit of confusion out there. Go ahead.
No, I was going to add something as well to that, in that I think you're bang on. It's really important that, we don't worry about what the rate is, but rather the reasons why women should have a baby at a particular time. So I think the more that we can do to ensure that everybody that has the ability to do cesarean sections actually knows what their cesarean section rate is, the reasons why women are having the cesarean section rate, and then really the subgroups, of course, which are the low-risk groups, that they are having a cesarean section at an appropriate time. And I think that actually, I think increasingly in our own environment, we're seeing that actually it also extends to women that actually have risk factors. In other words, increasingly we're saying, should we do it now or should we wait a few more days?
Yep.
Okay, so it's kind of an informed decision about and balancing all the ins and outs of what the potential harm is and what the potential benefit is, and then balancing those two. And as I said earlier on, prematurity trumps a lot of things. And I'm honestly, personally, I think I'm on that extreme side, but I think obviously the truth is in the middle there somewhere. So I agree with you that we should make sure that people don't get confused and say, we're talking about a very specific group of patients, and yes, there are times when you absolutely have to do a cesarean section at a very different time.
Yes, absolutely. Thank you for that. We have just 2 more minutes left. I don't see any other questions in my chat box here on my screen. I'd like to just point people in the direction of 2 publications that have come out in 2013. One is about the pilot project that was done in the Champlain LHIN about this key performance indicator. It isn't about use of the dashboard per se, because the dashboard wasn't launched yet, but it does help to describe experiences in this LHIN and add it on to the wonderful presentation and the great work you're doing in London. We're hoping that helps to give people some suggestions of strategies to move forward. And interestingly, very consistently with what you're doing, certainly understanding your own data, auditing your cases, trying to explore policies, procedures, practices in your own organization to clearly understand the triggers for why your cesarean sections are happening for this low-risk cohort, less than 39 weeks, making some decisions, as you've done, about the type of policy and procedure you're going to put in place, hard stop, soft stop, or what what tailored strategies you need to do around scheduling, booking OR time. Certainly keeping this issue on the quality agenda and your departmental meeting agendas is the way to go. So you've given us wonderful food for thought, and I think great examples of some strategies that sites can use. There is another paper as well. The pilot project paper about this indicator was published in the Journal of Obstetrics and Gynecology Canada in April of 2013 this year. And there is also a Robson paper that goes into detail about the different Robson categories and looks at Robson data. And Sherry Kelly, our epidemiologist at Bourne, was the lead author on that paper, and it was also published in March of 2013 in JOGC. So it's just 1 o'clock. Our time is up. I would like to thank Dr. Chandra, Dr. Natali, and Dr. Graton for a wonderful presentation, and we do appreciate you taking the time to share this story with us and with the province. We know that it will give lots of information for people to explore further. Again, we will post this on our Bourne website. It will probably take a few days, won't be until next week, but it will be available. And just to let you know, our next Bourne provincial rounds, although we normally target the third Thursday of the month at noon for Bourne provincial rounds, we have a change in date. Our next one will be the fourth Thursday of October, so it will be October 24th. Stay tuned for announcements coming out in early October about that. We've just had a scheduling change, so if you're a regular listener, you can just put a hold in your calendar for that. So I would like to say thanks again to everybody. Thanks to everyone who signed on, all of the participants who signed on and who submitted their questions. Thanks to our presenters, and I hope you all have a wonderful afternoon and a great weekend, and we look forward to speaking with you next month. Thanks so much, all. Bye now.
Thank you.
Thanks, bye.